The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of those and should not be interpreted to reflect official policy or position of any entity aside from possibly Cash Like Moral Hospital and affiliate outreach programs. If indeed there are any, in fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back, guys. We haven't recorded. We haven't recorded in Skype in a very long time.
It's been about 2 months.
Yeah. we were
hours maybe.
But we were all just like holding hands, recording in person just a couple weeks ago. It was great.
Just a lot of deep eye contact. Yeah, it was magical.
And red shirts that you're still wearing.
Yes, yeah. I am wearing a red curbsider shirt. I always like to record wearing a curbsider shirt. Makes me feel more official. Stuart, I don't know what you're wearing there.
My pajamas. Why are you asking what I'm wearing? You really want to know? It's
okay.
like Jake from what? Allstate?
Okay. As everyone starts to tune out, don't tune out. We are talking about venous thromboembolism.
Wait.
Otherwise known
isn't
as
Paul supposed to say what we do?
Otherwise known as DVT and PE. But before we get to all that, Paul, can you tell the audience what we do on this show?
All right. Still frantically processing a red shoe diary joke. We are the internal medicine podcast, and we use expert interviews to bring you clinical pearls and practice-changing knowledge. And then we also like to get to know the guest a little bit at the beginning of the episode. I suppose you could skip past that, but why would you? But if you really, really feel compelled to, and your time is that crunched, you can certainly refer to the show notes that have timestamps.
So now we should probably introduce our guest host, Dr. Justin Lee Burke.
Hey guys, happy to be on the show as always.
And you want to tell them a little bit about what they can expect from this show tonight, Justin?
Absolutely. We have a great show lined up for you guys with Dr. Michael Streiff. We talk about VTE, DVT, and PE, some definitions, some approach to diagnoses, some risk stratification tools, and generalized treatment for each, and kind of the rise of the DOACs. And then we end with some great lightning round questions. It's a phenomenal show, guys. Just a great show.
Yes.
We love that word.
Definitely.
I really do.
It definitely answered a lot of things on my DVT PE wish list. Things mainly things that I get asked on a nearly daily basis that I didn't know the answers to. Now have a much better, at least idea. Well, I talked to this great expert, and this is what he said, which is my favorite. My favorite response. That's my favorite response. That's probably the best part of doing the show is I get to say that about like at what going on now 150-ish conditions. So. I guess
we've got this enough now that I can just say that, and people aren't going to fact check me. So even if I'm not perfect, I still have a pretty good leg to stand on.
I think I'm just around a tough crowd. I think maybe people just don't trust my face because I get people. I have to send references with everything I say. Our guest on this episode is Dr. Michael Streiff. His major clinical interest involves the prevention and treatment of venous thromboembolism. He chairs the Venous Thromboembolism Guideline Committee for the National Comprehensive Cancer Network and has served on international consensus panels to develop standardized guidelines for the use of vena cava filters in the management of venous thromboembolism. As medical director of the Anticoagulation Management Service and outpatient clinics at Johns Hopkins University, he has been actively involved in developing policies and procedures for standardizing anticoagulation management and guidelines for VTE prevention at Johns Hopkins. And let me tell you, this episode is packed full of incredible facts about venous thromboembolism. It's definitely going to be practice changing. So without further ado, please enjoy this extensive conversation.
Hey, Matt, do you know what you say to a hematologist when he graduates fellowship?
I don't know.
Coagulations.
I mean, they're just... It's simply amazing.
I actually don't hate that one. I'm not sure what that says about me. I must be exhausted.
Are these prepared or off the cuff?
This was off the cuff.
Yeah, that's pretty good.
Our first question for all our guests is always really easy. It's, can you give us a one-liner about yourself and definitely include something that you do outside the world of medicine?
Sure. So, well, thanks a lot for the invitation to join you guys on the podcast. And so I'm a Floridian, so I'm from Gainesville, Florida. So I'm a Florida Gator who used to love to surf. Don't do it so much anymore because I gotten old. Love heavy metal concerts. I used to go to them a lot less recently. I just gotten too busy, but I still, if Judas Priest is on tour, I'll go find him. And I love clotting. That's kind of me. I'm a pretty monochromatic kind of guy. Rock. I used to surf, although my surfboards sit in the my basement now because I'm out of shape. And clots. So that's me.
I feel
Lots
like Paul.
rock.
Yeah, I feel like Paul Williams has to ask the next question.
Okay.
Probably something about Judas Priest.
Awesome. What's your
Usually
favorite
I'm like-
song? Yeah.
Well, no, that's not even fair to ask. Usually I ask about book, but now you have me curious. So what is the last heavy metal concert that you've been to?
Oh, Judas Priest. They came through Baltimore a couple of years ago. I guess before that, Rat was here one time. They're kind of they're a hair band though.
Sure.
Kind of more. Yeah. Who else? The Cult was here a few years ago. AC/DC, I saw him a few years in Verizon Center. But
That's a pretty good run.
yeah, but Baltimore's kind of. Queensryche was here, I think, a year or two ago. So those are the kind of bands I listen to, much to my wife's disgust. She bans me from the I guess the iPod when I'm in the car.
Is that required listening on rounds?
No, I don't. No, I think I'd get a talking to by Sanjay or Mark Anderson would call me to his office and upbraid me about it. So no, I don't do that.
Or high fives all around. That's actually what I figured.
I'll go. One of the questions I always like, can you share the best advice you ever received, either as a learner or as a teacher or sometime along your career?
Yeah, so I got advice from, I guess as a student, Locke Conley was one of the professors here in hematology and medicine. And I guess he taught me a couple of things. One, persistence. He said, never, if you have an article that gets rejected 10 times, you just send it to the 11th place. And initially when you're writing articles, you get rejected a lot. And so that I've kind of incorporated that because I've gotten rejection a lot. Not just in writing articles too, but talk to my wife. It was a multiple. Anyway, no. She didn't say yes the first time I went out on the date. So that was one thing. I guess. What else is he? Oh, he also said always be thinking of if you have a question that comes up when you're on rounds or you're seeing a patient in clinic. Make notes of that. If that's something you'd like to study, always have study ideas. Think of what's the next idea you want to study and have at least one a week. And some of them you'll think about more and it won't make sense to study it. There won't be a good way to study it. But that's something else that he taught me. And Craig Kitchens also taught me that, who was when I was in residency at Florida, he said the same thing, told me the same things. And let's see, other things that, besides that, besides persistence, I mean, I guess in finding your niche and something you really love, like clots. I mean, it's a very small world of medicine, but I kind of fell into this because the person I love to work with here at Hopkins, Dr. Bell, did it. And so I saw lots of patients with blood clots and followed him around like a puppy dog. And then, and then I've kind of focused in that area. So if you're going to be in an academic calling is in a medical center, then I'd find a niche that you really love because you'll want to do it all the time and you'll generally be successful. And I'm, I guess, somewhat successful at what I've done just by doing it a lot, And I think it's much harder to be an expert in lots of different areas. Like I think my hats go off to internists because, God, those guys have to know everything, something about everything. All I got to know about is hematology, so it's a lot easier for me.
So normally we ask about a favorite book or a book that you think everyone should read. What about movies? What's your favorite movie or a movie that everyone should watch?
I do have a book, actually. I want to.
Oh, you do?
I do. Oh,
okay.
yeah. I actually got it off my shelf because I have it on my shelf. That this is one well, you can see it. The Lost Art of Healing, and Craig Kitchens told me to read this as an intern, and I don't know, maybe it was I don't know if it was my bedside manner or something like that. He said, "Boy, you got to go read this book." But The Lost Art of Healing by Bernard Lown, who is a professor of cardiology up at Harvard, and it's kind of like it's a series of patient vignettes that taught me to be a better doctor. I mean, to really listen to patients, to kind of put yourself in the patient's shoes. It made me more empathetic, I think. And I think we all have, when you get into medicine, that's kind of inbred in your DNA. But to me, it brought it home to me. So I think that to me was a great book. It taught me a lot. And I still think about it when I'm seeing patients.
You probably thought you needed that to balance out your Judas Priest and heavy metal.
I guess
heavy metal obsession.
My wife would wish I'd do this more, read this more than listen to heavy metal or buy stuff from iTunes. But anyway.
Well, I want to give us plenty of time to talk about DVT and PE, venous thromboembolism. Justin, why don't you start us off with a case?
Great. So in the clinic at Catholic Memorial, we have a 64-year-old female named Emmy Bolism. She was recently hospitalized for a total hip replacement surgery. She comes to the clinic with pain and increased swelling in her left calf. On exam, she has pitting edema just on her left leg. She has new superficial veins and some localized tenderness. She's not febrile. There's no other signs of skin changes suggestive of cellulitis or infection, and she's never really had this type of swelling before. So taking Miss Bolism in account, wanted to kind of have you talk about the diagnosis of a DVT or VTE and kind of introduce some of the terms that we're talking with when we talk about blood clots.
Yeah, so I guess we talk about the world of venous clots. The disease, we call it now venous thromboembolism, is kind of an umbrella term. And that refers, at least to my mind, refers to any vein clot. So it can be a deep vein thrombosis, which is a clot that can be either in the distal veins of the calf, such as the perineal vein, or it can be a proximal DVT, which are much more dangerous, obviously, in the popliteal veins and up from there into the femoral and iliac veins. And then if you have a DVT and of course you can also have it in the upper extremities too. And then you can have if it embolizes, it becomes a pulmonary embolism, which is what we try to stay away from or try to prevent while treating our DVTs, when we making the diagnosis early. And then I also count superficial vein thrombosis or superficial venous thrombophlebitis because if they progress, can become a DVT and are treated more and more like we used to treat them with nonsteroidals. And I think more and more, if you have large superficial vein thrombosis, you're treating that with an anticoagulant rather than nonsteroidals and warm compresses, et cetera. So those are really the major venous clotting events that we think of on the umbrella of venous thromboembolism. I guess some people may throw mesenteric or splenic vein thrombosis in on that, or cerebral venous sinus thrombosis. But the major ones, the most important ones, the most common ones are deep vein thrombosis, pulmonary embolism, and then superficial venous thrombosis or venous thrombophlebitis. And then so as far as diagnosis in our young woman here that has sounds very much like she has a deep vein thrombosis, is that the symptoms of it are generally the most common symptom I hear people relate to me is if they've got a lower extremity clot is kind of a crampy pain in the calf that just won't go away. So it's like having a leg cramp that you can't walk off, that you can't massage out. And then oftentimes, not always, but oftentimes with that, they'll have distension of the calf or feel like they have a pressure sensation in the calf. You can have, and then signs, you may have changes in the color often, changes in the size of the limb, edema in the ankles. And often then you also think about what kind of triggers that might have contributed to this, because a lot of clots have a trigger. In this person, they had surgery recently. So major surgery is a huge risk factor for deep vein thrombosis or pulmonary embolism. It's the biggest of all. I mean, it raises your risk about 100-fold compared to the baseline risk of the population. So someone that's had a surgery recently and comes in with any lower extremity symptoms, you got to put, DVT way up on your lists several times, I would say. And that's what, some of the pretest probability models are based on, like the Wells criteria are based on kind of signs and symptoms that make you think it's a deep vein thrombosis rather than a cellulitis or edema from congestive heart failure.
And are there any historical features that really raise your eyebrows? So you mentioned recent surgery. I know malignancy. I feel like in my own practice, or at least talking to others, like I'll hear things like, well, they're obese, or they smoked a cigarette once, or they took an oral contraceptive in 1973. And so what things really make you nervous? And then what are the risk factors, or maybe not as contributory as we might think?
Yeah, no, that's an excellent question. So I think that obviously surgery and cancer are very big risk factors. But other ones would be a recent hospitalization. They were recently in the hospital and have just come out in usually that's within the last few months or so. And with surgery, I didn't put a time frame on that. Usually you're thinking about surgery as a risk factor for about, most of the risk is in the first 6 to 12 weeks. And then after that, the risk goes way down after that. And there are nice studies from Great Britain looking at like the time course of when DVTs occur and PEs occur after surgery. And a lot of it's front loaded in the first 6 weeks, but it doesn't go down toward baseline for months and months afterwards. But you're really thinking 3 months after the surgery as being the risk period. Same thing for a medical hospitalization. Oral contraceptives or hormone replacement therapy, not as big a risk factor as surgery or cancer, but certainly if someone has just started an oral contraceptive or just started a hormone replacement therapy, which fortunately we see a lot less these days, that is certainly something that it raises your risk 3 to 4-fold. So I would definitely ask about that. And I ask about if people are using excessive use of testosterone. Not replacement doses don't seem to be a risk factor for DVT or PE, but if someone's juicing, that we've seen people have events in that setting. For estrogen, it's usually in the first 6 to 12 months is primarily a risk factor. And once you get beyond that, it's much, much less a risk factor. And so when I see someone in clinic and they say, oh yeah, I've been on it for 10 years, then I discount that to a large extent, or even a couple of years, because then I think of that person's clot as more likely related to something else, or putting them more closer to the unprovoked category rather than an estrogen associated event. Pregnancy, that's a risk factor that we have to think about. Obesity is a risk factor. It's kind of doubles your risk, and as your BMI goes upward, may get up to, in some studies, as high as 4-fold over the population. But I mean, that's big. We're talking people with BMIs 40 and 50 when you're talking 4-fold. So you're talking big people. But again, it's that's I guess much smaller risk than our major ones, which are cancer and major surgery, medical hospitalization.
Dr. Streiff, I wanted to the stuff you're kind of talking about, and you mentioned it already, the Wells score for DVT. And I should point out to the audience, there's a Wells score for PE and there's a Wells score for DVT. Right. The Wells score for DVT has a lot of the historical risk factors you're talking about, and then it also combines in some of the physical exam findings. Right. So is there, are you carrying like a tape measure and actually measuring the calf circumference?
Oh, for the threes? No, no, I don't do that. No. I mean, if there's, obviously it's, I guess I have done that in clinic sometimes, but generally I'm not. If they have obvious calf swelling, then I'm counting that in the Wells score, and I'm usually pulling it up on my phone. Actually, the Wells criteria, because it's so easy to find, and all these, the 4T score, all these different pretest probability models, I pull them up on my phone, or Geneva. You could bring up the Geneva score. If you want to use the Geneva model for DVT-PE diagnosis, you could do that as well. Wells, I think, has been validated to a greater extent and has been around for a long while. So most people are using that. I think when they're seeing outpatients, In the inpatient world, I because it's mostly an outpatient tool, I haven't used it in inpatients. I use it more in clinic, or if you happen to be in the ED, that would be something I would use in conjunction with the D-dimer, which makes it a very powerful risk stratification strategy.
Right. So you're saying and I was looking up some algorithms. So I'm not. Maybe you can recommend to us a specific article or a specific algorithm you follow. But a lot of the articles were saying you kind of take the history, you use a clinical decision tool like the Wells score. So in this case, we could calculate a Wells score for our patient, and then they said if it's high probability, they would proceed right to ultrasound. But if it's a low or intermediate, then maybe you would do the D-dimer. But can you tell us what you like to do?
I usually end up sending a D-dimer on anyone I'm suspicious and do it just because it's we can get them pretty rapidly, and it's easy to do unless it's very obvious. I usually say if someone looks like they're an extremist from a PE or their leg is huge, then I just go to ultrasound. But if there's most of the time I'm doing a D-dimer too, if I'm in an outpatient environment.
The D-dimer. I've asked this recently to other people as well, but and I've got some varied answers over time. What do you do the age-adjusted D-dimer, and do you recommend that our audience does that for patients over 50? It's you multiply times 10, I think.
Yeah, I have been using that for older patients.
Okay.
The other people used, like in the years criteria that you'd mentioned, as another algorithm that people are starting to use, although it's not been around as long, that they use thresholds of like 500 and 1,000, and then in combination with the years, which are only like 3 criteria, like hemoptysis, that's for PE, but hemoptysis, DVT, signs or symptoms, and P's, the likely diagnosis. So it's a much simpler model. But I do use age-adjusted D-dimer when I'm looking at older patients, over than 50. Yeah.
Okay. Yeah. So for instance, if it's a 50-year-old person, you multiply age times 10. So five you would expect. Yeah. So you'd expect it either be 500 or 0.5, depending on the units your lab's using. 80-year-old person, 800 or less.
Right.
So if it's above that, you consider it elevated.
Right.
Okay. And you find, I guess the idea behind doing that is that you're supposed to be able to exclude, like kind of avoid imaging in certain patients?
Yeah, because it's over time, as we age, our D-dimer levels in the general population go upward. And so otherwise what happens is you find in older people, you're doing a lot more studies. You're doing a lot more ultrasounds or CTs. So it helps it make it a little bit more specific.
Okay.
Maybe not going into treatment quite yet, but once you have a clear diagnosis of a DVT, whether based on very significant physical exam findings and elevated D-dimer, or you confirm with ultrasound, what are the important factors used to categorize the clot, or what are the characteristics that will eventually guide treatment for duration of anticoagulation?
Yeah, so I guess you're either going to anticoagulate, or you're going to, there's, I guess, 3 paths you could go down. If someone's obviously has horrific bleeding or clinically bleeding and you're not going to be able to use an anticoagulant, then you have to start, or they just had neurosurgery, then you got to go down the filter pathway. I don't go down that pathway that often, but I do use vena cava filters when you obviously can't use anticoagulation. That's the only time I use them. Most of your patients are going to get anticoagulation is what you're going to do. And so that's generally the pathway you're going to go for the vast majority of people. If you have, and that would be for people that have, I still tend to treat calf vein DVT with anticoagulation. That's not universally done. In Europe, you'll see that people tend to, if they pick up a calf DVT, they tend to half the time do a serial ultrasound to see if they really need to treat it, because there are studies showing that not all calf DVTs become symptomatic proximal DVTs, and not all of them need to be treated. If someone comes to me, though, with calf pain and they have a calf DVT, I think it's pretty hard not to treat that. So I treat my calf vein DVTs with 3 months of anticoagulation. We might be able to get away with 6 weeks, but I think that the duration of therapy studies that have been done in that, there's only one real study that's really looked at that. it's 6 weeks versus 12 weeks. I think we need more data before you treat it 6 weeks. I might do that in someone that's really high bleeding risk. Otherwise, I do 12 weeks for a calf DVT. So if you have a calf DVT, I tend to treat most of those if they're symptomatic. If you have proximal DVT, obviously all of those. So that proximal would be popliteal vein, femoral vein, common femoral vein, and then iliac veins, going up from there. And then the final, I guess, treatment we don't do as much as we used to, I think, since the ATTRACT trial, is catheter-directed thrombolysis. And that would be if you have somebody that has a really big clot. So usually the people that are going to benefit from catheter-directed thrombolysis are people that are at low risk for bleeding. So it's usually younger people, haven't had recent invasive procedures, and they have large clots. So that usually means they got iliac vein involvement. And I tend to go down that pathway if someone has either a clot that's not responding to anticoagulation alone, or someone that I'm suspicious they have an anatomic reason for their clot, such as something called May-Thurner syndrome or iliac vein compression syndrome, where the right iliac artery crosses the left iliac vein and compresses it and causes basically vascular damage that leads to formation of a stenosis there, and then clot can form there. And often the classic case is a woman starts oral contraceptives, and then they come in with a iliofemoral DVT. So that's why it's always important to make sure you can see the top of your clot, the most proximal, area where the clot is. So if you can't see the top of it with your ultrasound, then you need to do imaging to make sure that you don't have May-Thurner syndrome, because those are people that you want to open up. If they're at low risk of bleeding, you want to open those people up because you usually want to put a stent in there to keep that open generally. So thrombolysis generally I reserve for people not getting better with their anticoagulation over the first few days, or people that have huge clots that are causing
like Major or something like that.
Exactly. Yeah. Right. You got arterial compromise, or their leg is just really symptomatic after a few days of anticoagulation. They're not getting better. Or someone I think has May-Thurner syndrome, because those people usually are not going to do well with anticoagulation. You're going to have to open that up. So, but that's a lot fewer people than we used to do more aggressive thrombolysis. But the ATTRACT trial that was published, I guess, like December 2017 or sometime in that time frame, suggested there really wasn't any benefit for post-thrombotic syndrome. So we don't do it anymore, except for really big clots.
What are your thoughts on placing IVC filters prophylactically in trauma patients?
They're just, the data are so poor, really, that we really don't have good data that show that they do anything. And so I think that the vast majority of people, you can get away with prophylaxis. You don't need to put a filter in. So I never advocate for putting them in massive trauma patients. I would say use mechanical compression stock, your SCDs. Start your prophylaxis when you can. A lot of times you can start it pretty soon. And the studies that show that filters do anything are often like before or after, like historically controlled trials. There's no randomized trial. And so I think that that's the kind of data we need to start doing filters, because filters have a lot of downsides. I mean, of course, I'm a little biased. The people that come to me with filters are usually people that have had troubles, but they fracture, their legs get into places you don't want them to get into. They cause recurrent clots. Mm-hmm. So I stay away from them. So I think it's very rare you're going to have a trauma patient. You're going to need to put that in unless they've developed a clot, and you can't put them on full dose anticoagulation. I think that's a rare patient. I think that we used to do a lot of it 10 years ago, and I think the trauma surgeons are doing less and less of it because they don't see that I don't think they see benefits to it.
Is there any difference in the way that you would approach, say, an upper extremity DVT versus a lower extremity DVT, just from the overall approach? Sure.
No, I think that's a great question. I mean, I think that, one, I am much less likely to anticoagulate for distal upper extremity DVTs, because a lot of those are due to like IV catheters. If you have a line in place And mainly where we see this are cancer patients that have either ports in place or Hickman catheters in place. That's a huge risk factor for upper extremity DVT. So if those people, if they've got a line in place, then generally you have to treat it at least 3 months. And if the line's still in place, you need to keep the anticoagulation. I try to keep the anticoagulation going because you still got your trigger in that vessel. The triggers you look for are lines. You look for thoracic outlet syndrome, which maybe you were getting to. So if you have someone that has an unprovoked upper extremity DVT, you got to think about thoracic outlet syndrome. That's usually a young person that's has done a lot of heavy lifting recently, or is a gymnast or a weightlifter. Not always though. So if they have an unprovoked upper extremity DVT, I'll look and you don't have lines, they haven't had any procedures up here, then I think about that. Or if you have an older person, particularly someone that has cancer, you think about involvement of the apex of the lung. I've seen that some where you get lesions that are up toward the thoracic outlet that cause troubles there. So those are the kind of things I think about. And then if you have a line, I try to anticoagulate all those people if I can. If you have someone that's got leukemia and has no platelets and you're not going to be able to support them through it, we do pull those lines. We try to give them anticoagulation if we can. It's nice to give it for a week or two to get the clot more, let's say, well organized. But we're in situations where we can't do that, and we pull lines in those people. Rarely do you get into trouble with clots going places unless you got SVC involvement. But I worry about it anytime you got subclavian or SVC involvement. I tend to treat anyone that's got axillary, subclavian, or more proximal involvement with anticoagulation. If they're further down, down more distally of the arm, I don't always treat those with anticoagulation unless they're having a lot of symptoms, but that's rare. Mm-hmm. So most of the clots I'm treating in the upper extremity are going to be proximal clots, so axillary and subclavian clots and IJ clots. Mm-hmm. And again, looking for triggers you can get rid of, such as lines.
Yeah. With PICC lines, does that go the same thing? You do, like, if someone has a PICC line for 2 weeks for IV antibiotics and then you pull the PICC line after 2 weeks, would you still give them a 3-month course?
Yeah, I mean, I guess I'd probably bias to that just because we don't know that less is better. But if you have someone that's going to be a high bleeding risk, or you're having to support them with platelets, or you could probably treat those a lot less. A lot of people treat a month or 6 weeks, but it's all based on this is kind of expert opinion, or observational data. There's no real randomized controlled trials looking at that. So a lot of all the treatment in the upper extremity is really observational data. There are no randomized trials up there. So
I wanted to swing back. You talked about the calf vein DVT, which sometimes in the literature they call like this isolated distal DVT.
Right.
When I was reading about this, they were talking about either proximal ultrasound, proximal compressive ultrasound, or whole leg ultrasound. Can you talk a little bit about how the ultrasound might be done? Just like if we're ordering it so we know what we're getting, are we missing clots in certain areas if we just get the proximal versus the whole leg? How do those differ?
Yeah, no, so that's a great question. And that's where I think the US versus Europe, you'll see big differences in this. In Europe, most of the ultrasounds that are being done in Europe are proximal leg ultrasounds, whereas you'll see in the US, particularly in vascular labs, but also in a lot of radiology labs, they'll do whole leg. They'll look all the way down to, posterior tibial veins, perineal veins. They'll go all the way down into the calf. Whereas in Europe, they don't tend to do that. And the reason they don't tend to do that is there have been studies looking at comparing what you find with a whole leg ultrasound versus proximal leg ultrasound, and then looking at outcomes of if you randomize people that have leg symptoms to either proximal leg ultrasound versus whole leg ultrasound. If you'll follow those people for 3 months, the people that you just did proximal leg ultrasound on, there are very few that are having recurrent events. And so the Europeans have pointed to that and said, well, some of those people have had calf DVTs that didn't progress. And that's why there's I would say a move in Europe where they're treating fewer and fewer calf vein DVTs, or treating them shorter periods of time, 6 weeks.
Okay.
In the U.S., we treat. I think we're much more aggressive about treatment. We treat calf vein DVT. But yeah, I think, and I say this to my European colleagues, I mean, if someone comes into you with calf pain and you do a proximal leg ultrasound that's negative and they have a positive D-dimer, how are you going to, I mean, I'd have to look below or do a serial ultrasound. And how are you going to leave that person alone? And in Europe, maybe you can bring people back in a week for a serial ultrasound. To me, I want to know the whole leg. And if they have symptoms, I'm going to treat them.
Okay.
So I think in Europe, maybe you can get away with that more. Here in the U.S., I think everybody has whole leg ultrasound and goes after it.
Right. So I think proximal, from what you're describing, I think they just check the femoral system and then the popliteal system and call it a day. Versus whole leg, they would go all the way down. Okay.
Right, exactly.
And then if you are just checking proximal, from what I saw, the serial ultrasound, it seems like some people do a week or 2 weeks follow-up ultrasound.
Right. Exactly. In a week, they bring them back and look again. Yeah.
Got it. All right. Justin, maybe we should move on to the next part of this and we can kind of delve into PE a little bit and then go into the treatment.
Sure. Yeah, so quickly, we can, while in clinic, our patient, Emmy, is starting to feel worse right in front of your eyes. She acutely becomes somewhat short of breath. She's complaining of some new chest pain anytime she takes a deep breath. A nurse places a pulse ox, and she is satting at about 87% on room air. Her other vital signs include a heart rate of 102, blood pressure of 128/78, and a respiratory rate of 24. She's placed on oxygen and sent to the emergency department. So we talked a little bit about the diagnosis of DVT. Can you guide us a little bit through the diagnosis of a pulmonary embolism?
Sure. So in this person, I would go straight to a CT angiogram. I mean, you could use Wells criteria and D-dimer, but I think this scenario sounds like this person needs a CT. And with that CT, you'd get how much clot is there. Do they have a proximal or distal involvement of the vasculature? And depending on how they report out your CTs, you also might see if the person has right ventricular overload or not. Some people send troponins or pro-BNPs to look for right ventricular overload. Others use use echoes to do that. And this person sound like they probably have a submassive. They don't sound like they've got a massive. Massive would be hypotension, or that you'd have that where you've got hypotension. She doesn't have that at this point in time. But it sounds like she's got a significant pulmonary embolism. So I'd get CTA. I mean, obviously you'd start your anticoagulation, get a CTA, see if the CTA shows you that her RV is overloaded. You could do an echo if you don't get that information from your CT to look at that. I don't send the troponins and pro-BNPs off, although there are people that do that. They seem to be pretty sensitive, though. So they're often elevated.
I wanted to ask, in this case we gave you, it seems pretty obvious that the move is to jump to the CT pulmonary angio, but it seems to me like clinically it can be kind of tricky to diagnose a pulmonary embolism. Can you speak to that a little bit and how you recommend we go about sort of like working these patients up, or what algorithm you use, or what decision tools?
Yeah, so I think in this case, obviously you jump right to your CT. But if you have, you're right. Ps can be have very vague symptoms, such as like I feel a little short of breath, or it's a little harder for me to go up the stairs, and and they won't have any chest pain at all, so they just feel a little out of shape. And then if you're suspicious of that they have a PE, then those people you could do a D-dimer in and look at Wells criteria. Do they have any swelling in their legs? Do they have risk factors, recent surgery? They have cancer? Do they have recent hospitalization? And if your D-dimer was elevated, then you would go to a CTA. I usually go to CTA. I usually rarely use a VQ scan because I don't find that you get a lot of reads that are like 30% of the time, maybe as high as 50% in some studies. You get a read that is not helpful. It's not normal. and it's not clearly a high prob scan. And so I find that not so useful. So I don't use VQ except maybe in someone with renal failure, you might use it. We used to use it some in pregnancy, although there's arguments about, it's the baby probably gets exposed to more radiation with a VQ than they do with a CT. And if you use shielding, you can probably get a good CT, or you can just go to ultrasounds and look if you're in a situation where you don't want to, where they got leg symptoms, they got chest symptoms, you don't want to give them contrast, you could do ultrasound and then just treat them as if they have PE. So, and as far as like, I guess you've had to talk about this, but as far as like their risk of having bad outcomes, you can use PICC scores for that. A lot of people use the PICC score.
Yeah.
Or Hestia criteria. I know the ED here uses Hestia criteria often to decide whether they're going to send somebody home. I think most people are pretty anxious about sending someone home that's got any hypoxia, any submassive P. They're not going to go home. The only people you're going to send home out of the ED are people that have like incidental events or people that are minimally symptomatic. I think it's in the US, it's difficult. In Canada, they'll send people home as if they're not hypoxic, just regardless of the size of their clot, they'll send them home. If they're not hypoxic, their blood pressure is good, they send people home like that because it's rare for people to get into trouble. But I think in the US where it's more litigious, most people don't do that. They'll bring them in for at least a day or so to make the highest risk period of time where they're going to deteriorate is going to be the first day or so. They'll bring them in for that. So I think very few people are sending people out, except where you have a very small subsegmental event that's not suspected. Those people probably get treated as outpatients.
I want to try to summarize a little bit from what we've talked about so far. So it sounds like it's useful to use the Wells or the Geneva, whether we're considering DVT or PE as a diagnosis. Right. If it's high probability, we're going to proceed right to either an ultrasound for DVT or a CT pulmonary angiogram for if we think that the person has a PE. Exactly. And then if it's low probability or intermediate, maybe we'll send a D-dimer first to decide if we need that second test, the ultrasound or the CT. Okay. Yeah, I mean, it's just, I find that it's useful to use those tools because it's just like so tricky. I think it was like one of the PIOPED studies when they looked at the symptoms people had with PE, like many people don't have the classic symptoms you think. So it just seems like it's kind of a crapshoot. That was my read of it.
They could have back pain. They could have, just feel out of shape. They can, there's all sorts of symptoms that people just feel tired.
Right.
And then have a PE.
Okay. And you referenced our other show. We talked with Dr. Owen Friedman. I think it was like episode 90 something, and we talked about a lot of the Hestia and the PESI score and things like that. So I think with the rest of our time with you, I would love to hear a little bit about your approach to choice of agent, and let's talk about a little bit of the anticoagulation. That's definitely something we haven't got into, and I'm sure the audience is going to love to hear your thoughts on that.
Sure.
So for this lady, let's say we confirm that she has a pulmonary embolism. How might you decide, and what might be your go-to agent for her?
I mean, I think she's someone I'd be wary, just because it sounds like she's very symptomatic. I wouldn't stick her immediately on. If there's someone that I think may deteriorate, may need, a PERT team or a rapid response team, that's not somebody I'm going to use a DOAC. I use DOACs a lot, so I use Rivaroxaban, a Pixabay a lot for especially DVTs or Ps that are not where I'm not concerned about deterioration. So they're not. I wouldn't use those right up front in a submassive PE. Because I'm worried if they need to go for an intervention and they need a catheter embolectomy, if they need thrombolysis, I'd rather have them on heparin or low molecular weight heparin. So most of the time, if they're coming to the hospital, I'm worried about deterioration, I'm putting those people on low molecular weight heparin or heparin, just because those agents allow you a lot more flexibility if you need a procedure, especially heparin. If you really think they're going to go, the IR group is going to get involved and do potentially a a catheter embolectomy, then you don't want people on something you can't turn off that's going to make things more complex. So DOACs I reserve for mostly outpatients. And I use low molecular weight heparin or heparin in people that are coming in the hospital, or once we have an idea that they're not gonna need advanced care, they're not gonna need TPA, they're not gonna need a catheter embolectomy, they're gonna do all right. Then I'd switch to DOACs. I'm using DOACs for almost all of my patients with a DVT or PE now. And that's also, including now the cancer patient population where DOACs, we used to use low molecular weight heparin was first line for all the cancer patients. And now that's everybody's kind of moving toward a Pixabay, even though there's only one trial that's out. That's a small trial of 300 and something patients. The ATOM trial hasn't been published yet, but it looks the results are very similar to the results in the SELECT-D study with Rivaroxaban and with the Hokusai cancer VTE study with Edoxaban. So all the DOACs are kind of looking like they have the same characteristics compared to low molecular weight heparin. And so people are all moving toward a Pixabay and Rivaroxaban.
Right.
Go ahead.
I was going to say, is this even for patients that are receiving active chemo?
Yeah. So I think that you can even use it in people that are active. So I think our oncology group is now, they're used to use a lot of low molecular weight heparin, and they're switching up because patients don't like it. They don't like the injections. It's very hard to keep people on low molecular weight heparin for long periods of time. I'd say there are occasionally, if they have to be on agents, it might be a drug interaction. So azoles, posaconazole, or something like that. Or if they have to be on rifampin, which is a drug interaction with all the DOACs. There are a few of the chemo agents but there's not a lot of them that cause problems. So unless they have to be on an agent that cross reacts with a Pixabay and a Rivaroxaban, they're using it in patients that are getting active chemo. And all those studies are, these are all active. The Hokusai patients, a large percentage of them were getting chemo, 75, 80%. Same thing in the SELECT-D study. Most of those patients were getting active chemo, unlike the previous studies, which were mostly, a very small percentage of people had active cancer. And the same thing with the ATOM trial. Most of those people are getting active chemo. I think the ones where we need to be a little nervous about using a direct oral anticoagulant would be people that have GI, especially upper GI malignancies. It looks like the bleeding rates were higher in people that had GI malignancies, particularly gastroesophageal. And I guess it makes sense. You're putting an active anticoagulant right on top of lesions that may be friable. And so I can see why those people, you get into trouble with direct oral anticoagulants.
Do you worry about patients with a high BMI, say greater than 40 with direct oral anticoagulants? There's been some studies that have looked at those patients and suggested that they have reduced peaks.
That's a great question. And yes, I do. That is one group. I mean, that's one group that I would worry about as far as that, because we know the blood volume goes up with body weight. Now it starts kind of plateauing once you get up, above like 120, 130 kilos. There's not a linear correlation as you go up to higher weights. But nonetheless, I would be concerned about drug levels in those people. We know from the RELY study, which was an AFib study, they measured dabigatran levels, and they were lower in people that had the higher weights. And when you got really low weights, you had higher levels and a little bit more bleeding. So there was kind of a U-shaped curve in those folks. Big weights having lower. So I think we need more. And that's why you see in the ISTH summary, the ISTH guideline, they suggest that with weights over 120 kilos or BMIs more than 40, to be very cautious with DOACs until we get more information. There are people doing studies right now on that, but I'm cautious with the agents once you get above 120 kilos.
And is there a preferred DOAC that you have?
I like a Pixabay the best of the group. It looks like the the clotting and bleeding is the lowest, clotting is about the same as warfarin if you compare all of them, but bleeding rates are lower with apixaban. So we've been using, also, I think if you look at the pharmacokinetics of apixaban, about a 12-hour half-life in most people, and you're giving the drug every 12 hours as opposed to Rivaroxaban, where you half-life's 5 to 9 hours in the young set, maybe 12 hours in the older set, and you're giving it once a day. That seems you're getting big peaks and lower troughs with that drug. And so I think apixaban, and that may be why you have a little bit more menstrual, menorrhagia with Rivaroxaban than you do with apixaban, although they both seem to be a little worse than warfarin. So I like apixaban the best of all the agents, although I use Rivaroxaban and apixaban primarily.
Has there been any ongoing trials or studies looking at Rivaroxaban twice daily, just like the reduction? It's recently approved by FDA for reduction of major cardiovascular events for Rivaroxaban twice daily with aspirin. Is there anything that's looking at this for DVT-PE, and specifically because of the half-life being much lower for Rivaroxaban?
Not that I know of. Not that I haven't seen any studies looking at that. I think they looked at it very early on in the drug's development, in the first, the phase 1 the very early phase 1 studies. You could find poster presentations in Europe on it, but not since then, that they went with a once daily regimen.
This kind of leads into the other thing I wanted to ask about, which was sure. we find someone has a DVT or PE, and let's say, how do we decide if we're going to do more than 3 months of therapy? Yeah,
so I'd say that obviously if you have a triggered event, a strong trigger like surgery, that's a 3-month person, unless they're still struggling, unless they have major limitations. Their mobility's they're not recovered from their surgery. They're still having complications, that I'd probably stretch things out. But for the most part, a surgically triggered event, if they're back to baseline, 3 months is all you need for those, because you had a very potent trigger, 100-fold increase over the baseline of the population, and that goes away over time. It's time limited. Estrogens, if your estrogen stopped, and I would think those are people you could think about on the shorter side. They have a lower risk of recurrence, although it's not zero. Mm-hmm. And medically ill, if you've got a medical, someone that hospitalization, they were very sick, they've recovered to a large extent at 3 months, then I would say yes. If they're still not recovered, or their inflammatory state, their inflammatory bowel disease, their rheumatoid arthritis, their lupus or whatever is still very active, then I'd probably keep medical people on longer, because they non-surgically provoked events tend to have a little bit higher recurrence rate. For the surgically after 3 months, 3 to 6 months after surgically provoked events, you got about a 0.7% per year recurrence rate. So very low, lower than the bleeding risks. Medical, they're in about the 4% range or so. And then the highest risk people are your unprovoked people, or people that have major ongoing risk factors like cancer. And those are people that you're going to keep on as long as the risk factors there, says cancer, they're going to stay on it as long as their cancer is active, demonstrable in scans, or they're still receiving treatment. As long as they're on treatment, you're going to keep them on. Unprovoked patients, I usually keep them on for long term. If you're concerned, if you want to try to figure out if someone, let's say you have somebody that is airline pilots, or someone that wants to stop, they want to stop therapy, they had an unprovoked event, then I usually try to risk stratify those people. The best model that's out there is the one that's been most validated is the HER2 model that Mark Rogers published a couple of years, back in 2008, and then had a validation study published in like 2017, I believe, in the BMJ. And that's in women, you can identify people that have a low risk of recurrence. And HER2 stands for people that if you have basically a lot of swelling still in the leg, so they have a lot of signs of post-thrombotic syndrome, that's a point. If they have a lot of erythema on the leg, if they have if they've had D dimers are elevated, if their age is older than 65, if they're obese, and those all give you points. And if you have, and you measure the D-dimer on therapy. So if your D-dimer is above, actually they use a threshold of 250 nanograms per mil, which is pretty low. So if you're below that, then you don't get any points for that. But if you have 2 or more points in that model, then you're at higher risk for recurrence. And those would be people that they would say you should stay on. If you have,
and these are people with an these are women with their first unprovoked. You can use the HER2.
Right.
Got it.
And so those people, they have a 3% or less risk of recurrence per year in people that have low risk. Men, unfortunately, tend to be about twice the risk of recurrence of women. So that model really didn't identify a low risk group of men. Other people there's a Vienna prediction model that you can use that less validated. That I assume a validation study is ongoing. The DASH model is another one that D-dimers, hormones, age, and gender. And that one has also been validated in retrospective populations, but not a prospective study. So I use those along with D-dimer to kind of identify people who are at higher risk for recurrence if they want to come off. In men with like pulmonary embolism, my bias is to keep those guys on because men have a higher recurrence rate. And people tend to recur with what event they had the first time around. If they had a PE, about 80% of the time they have another PE. And
with all these, we're just for the audience, we're talking about first unprovoked DVT. You use these models to determine if you're going to keep them on for indefinite therapy,
or if I'm going to take,
or if you might take them off.
If I'm going to take them off, if they want to really get off, then I say, okay, well, this is and I use it as a way to, also for like counseling that, if your percentage of recurrence is 8% per year based on this model, then I'm nervous about, that's much higher than the bleeding risk of being on a Pixabay or Rivaroxaban. I think that you're putting yourself at risk. So I use it. Even if they want to go off, I say, well, this is your, I would counsel you against this, but this is your risk if you want to go off because you want to be a police officer and you can't be a cop on anticoagulants. So I use it in counseling too, but my bias is in men that have, first pulmonary embolism or DVT. I tend to keep them on longer. And women, I use HER2 if they want to come off. And if they've had recurrent, obviously unprovoked events, then you're kind of on long term. If you've had triggered events, not necessarily. I mean, if you had surgically triggered events, then that's not someone you'd have to go on long term on. You just use better prophylaxis next time around.
Well, I think this is kind of leading one of the questions in the lightning round. I'll ask the first one, Justin. You can move us to the next. Thrombophilia workup. Do you find that useful at all? Because you just gave us away. Okay, good. That's good.
I don't. I mean, I guess the only thing would be if you're concerned about antiphospholipid syndrome, that would make you nervous about using a DOAC in a patient. If you're really concerned about antiphospholipid syndrome, then you don't want to use a DOAC, at least at this point in time. And so then I would test that. Otherwise, I don't use do a lot of the other testing. Yeah.
Okay. As a fun pearl, if someone did have antiphospholipid syndrome, what would you use for the treatment and what blood test would you use to follow their anticoagulation?
Yeah, so if you have someone that has antiphospholipid syndrome, you don't want to, right now, we don't think DOACs are safe for them. We've had the TRAPS trial came out last year in blood. They had a much higher, like a 5-fold higher recurrence rate in Rivaroxaban than they did in warfarin. So you definitely don't want, so you'd use warfarin. And generally you can use an INR of 2 to 3. In our clinic, we always check, if they have a lupus anticoagulant, I'm concerned about the antibody affecting their INR and actually can make people look therapeutic when they're not therapeutic. And this is one of the things one of my patients taught me years ago is that they had a recurrence and they were therapeutic, but when you check a chromogenic factor 10 activity, they were not therapeutic. And so I think if you've got someone that's got a lupus anticoagulant, once you have them in the therapeutic range 2 to 3, I would check a non-clot based assay to make sure that their INR is actually therapeutic. And that would be like a chromogenic factor 10 activity. That's what I would do. And we do that. And you have to avoid the point of care monitors for iron if they have a lupus anticoagulant. This does not apply to cardiolipins or beta 2 glycoprotein antibodies. So warfarin is still king in the antiphospholipid syndrome.
Right.
Another quick one for you. Should I do an extensive cancer workup for every patient with DVT and PE that is unprovoked?
No.
Yes, Matt.
No, I would. We have two studies that show that the SUM trial, and there was one in Europe as well. They both show that it's not, really not picking up cancers that change people's outcomes. And so I would just do age-appropriate screening, and that's it. You stop there.
All right. Eddie, last-minute questions for Dr. Streiff before we let him go.
Can we do the final 3 lightning round real quick?
Yeah.
They're quick. Yeah. So if there's a subsegmental pulmonary embolism found incidentally on imaging, are these patients that we should treat with anticoagulation or not treat?
So in patients with cancer, I probably would still treat them because the outcomes don't differ from people that have more proximal events. In people that don't have cancer, if they don't have DVT and they're at high risk for bleeding in the anticoagulation, I wouldn't treat. That's someone I wouldn't treat. So, but you got to look for DVT in those people. But I would caution that there is still data suggests that the outcomes of those people are very good, but it's still we don't have a management trial like randomizing people to just follow up versus anticoagulation. I think that's something that needs to be done. There's a registry study going on right now in Canada with Mark Carrier. They'll give us more data. Right now, a lot of it's retrospective data that's showing that isolated subsegmental PE is a disease that may not need to be treated. So in high risk people, for bleeding, without DVT, I definitely wouldn't treat them. No.
Great. Another question for Pixabay. Early on, it seemed like people had some hesitancy to do full dose of Pixabay in end-stage renal disease or chronic kidney disease. Does a Pixabay need to be renally dosed, or what? How does a chronic kidney disease change a Pixabay dosing?
Okay, so this is an area of evolving. There was a large observational study published in Circulation back in 2018 that suggested that outcomes were better with a Pixabay 5 milligrams BID than 2.5 milligrams BID in AFib patients, and both those are better than warfarin. Warfarin is worse compared to a Pixabay. Now, I would caution that is a observational data set, so you really can't use observational data sets to be the definitive about how a particular drug performs against another drug, because there could be other reasons that are influencing people's use of a Pixabay or warfarin. How do they get in those two arms? You need a randomized study to do that. There is one going on right now in AFib, in end-stage renal disease, so that'll give us the definitive answer. Right now, I admit I have put people on dialysis who would not use warfarin or were having calciphylaxis, or I have a handful of people on a Pixabay. They're all on 5 BID right now. I think you ought to go with 5 BID. I have used levels in some people because a couple of my nephrology colleagues have had bleeds. Most of the levels are okay, actually, which is surprising.
Wow.
So I'm very surprised. Because 25% of the drugs getting out of the body through the kidneys. Yeah. But I do look, even though people will caution you against using levels, it's all we got right now. And so if you want reassurance, I use peak levels of a Pixabay in that situation.
Our third episode started off with me ranting about a patient with CKD stage 3B who started on a Pixabay 10 milligrams twice daily with dual antiplatelet therapy. I nearly lost it when that patient came back to me from outside hospital.
Yeah, there's actually a great trial that this has nothing to do with DVT-PE, but the Augustus trial just came out a few weeks ago for the AFib, ACS set that looks really. I mean, it looks. Pixabay with Plavix looks really. You don't need to have the the DAP with it. So
right,
that's a study I would look at if you haven't. But
this has been amazing.
Oh, well, thanks. I don't know. I'm sorry I talked too much on some subjects, but no, thanks. It's great to talk to you guys. Good questions.
This will be tremendously helpful to the audience. I predict this will be a very popular show, and we can't thank you enough. We need to let you get home, get on with your night.
So hold on. He's a hematologist. Don't you want to ask him if there's anything he wants to plug?
Sure.
Oh yeah. Oh yeah.
That's a pun.
Perfect.
That's a pun, by the way.
Oh my God. But I would plug one for patients that have questions about DVTP or clots. National Blood Clot Alliance, great website. It's called Stop the Clot. I would go there. If you have anticoagulation questions, I mean, obviously there's American Heart is a good website. The AC Forum or Anticoagulation Forum is a great website that has all sorts of materials about anticoagulation, and it's basically a big organization of AC clinic directors and pharmacists and nurses. So AC Forum and National Blood Clot Alliance are the two plugs I would put in there. Oh, the ASH guidelines. Look at the ASH guidelines. They're coming out now.
All right.
Nice.
All right.
Excellent. Excellent.
That's Judas Priest on their next tour. I think they're touring right now, actually.
I think Paul Williams is a big Judas Priest fan.
I would love to go to a Judas Priest show. I'd be fine with that.
I am pulling them up on Spotify as soon as we're done here because I got to check
You're not going to get
out.
a DVT or PE at a Judas Priest show.
Yeah, see them now if you want to see them because they're in their 70s, I think. Those guys are going to die soon. So,
I think
anyway,
that's a perfect place to end.
I think it's right. I'm getting punch drunk. Yeah, so I'll stop there. Thanks for the invitation, guys.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy, Paul.
Nope. Get your show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
That's right, Paul. They're going to be in your inbox because we're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on iTunes, or contact us at thecurbsiders@gmail.com. A special thanks to our producer for this episode, the one and only Justin Burke, and to our social media team, Hannah R. Abrams on Twitter, Beth Garbatelli on Instagram, which I saw for like the first time because I don't have Instagram. And Chris the Chew Man Chew on Facebook for everyone else that's over the age of 40. Until next time, I've been Dr. Stuart Kent Brigham. Good night.
I've been Dr. Matthew Frank Watto.
And I've been Dr. Justin Lee Burke.
And I remain Dr. Paul Nelson Williams. Thank you and goodbye.
Oh, hi, Paul.
Yeah, I got to check out Judas Priest. I love their name. I don't
heard
think I've
Judas
heard
Priest. You cannot have grown up in the 1980s without have heard of them.
I probably just don't. I have to listen, and I'll probably be like, oh, that's who they are. But
Breaking the Law would be the one I think you would probably.
oh yeah, okay, fine.
So if you've seen Beavis and Butthead, you know Judas Priest.
Yeah, I do.
Yes.
I do.
Yes.
Yeah, that's what I was gonna say. I was gonna be like, oh yeah, you have the same taste as Beavis and Butthead because they're wearing all this. They're wearing like AC/DC, Judas Priest. Yeah,
Yeah, that's the only reference.
You should have asked him about Beavis and Butthead. He probably liked it.
I'm sure he did. Who doesn't like Beavis and Butthead?